All right, welcome everyone to this week's edition of It's Worth a Shot, presented by Mountain Pacific Quality Health. My name is Jessie Kinsey, and I'm an account manager with Mountain Pacific here in Montana. And this week's edition, we're going to cover COVID-19 preventative agents. And we also are going to discuss wellness in the new year. Today is December 21st, 2022, and thank you everyone for joining us. Next slide, please. Just a little holiday reminder that next week we will pause our weekly session for the 28th of December, and we'll resume on January 4th. And of course, we wish everyone the very best in the holiday season, and we will reconvene after the new year. Next slide, please. As always, any webinar topics or clinician ideas, feel free to drop those in the chat box. And again, next week we are paused to celebrate the holidays, and we'll resume January 4th. Next slide, please. Oh, and a polling question. How long has your infection preventionist been in their position? I see folks are still joining us from the waiting room, so we'll give you a few moments to respond to the polling question. Again, how long has your IP been in their position? Looks like about 50% of folks responding so far are less than a year, 30% 1 to 2 years, and about 21% 2 to 5 years. All right, we'll go ahead and end that poll. As always, thank you guys for participating in those. It's helpful. All right, next slide. So our weekly influenza snapshot, we did get a little bit of a plateau and a decline in positive cases. This is the national average, mostly still influenza A is what folks are testing positive for. I will note that it looks like there was actually less tests or individuals being tested this last summary period, so that may account for some of that decrease. I know in our regions between Alaska and Montana, Wyoming, we are still seeing a pretty heavy respiratory season and impact on our school systems with influenza A. So still a great time to be vaccinated and get vaccinated if you haven't yet. Next slide, please. And looking at the weekly COVID-19 snapshot, we did see a little decline in cases, continuing to see a little bit of a decline in deaths, which is obviously positive news, and a decline in hospitalizations. Vaccinations for those folks that are up to date, still less than desired percentage, about 14% of those eligible have received their updated booster. So again, just a friendly reminder that perfect timing to get your up-to-date vaccine as well. Next slide, please. New resources to align with the White House 6-week campaign. We recently launched a checklist of best practices to keep COVID out of the nursing homes, including the recommendations for vaccinations, and that can be located on our website. And we also released on the listserv today bivalent booster letters. Those were a series of 3 letters that your medical director could utilize, your center, or perhaps your administrator in communicating the importance of vaccines with your residents and your families. And those are endorsed by our in-house pharmacist as well as our medical director. Again, that will be on the website. Next slide, please. So without further ado, I'd like to welcome our first guest, Stephen Creasy. He's a pharmacist, Director of Clinical Services with PharmAmerica, and he's going to be chatting about COVID-19 preventative agents and treatments.
All right, thank you, Jesse. And good morning, good afternoon to those of you. We can go to the next slide. So in terms of preventative agents, I'm actually going to kind of skip that because I think you probably all understand and know that that's really the vaccines, right? There is one monoclonal antibody to the left there called Evusheld, which is for pre-exposure prophylaxis, and that's really for individuals for sensitivity reasons, anaphylaxis, that type of thing, that they cannot receive a vaccine. That's what that AGES is meant for. But what I really want to call your attention to is the red box section in the middle here. This is an adaptation of the NIH's COVID-19 prevention and treatment algorithm. But what's in the red box is, and this is a lot, but it's the agents that are used for the treatment of mild to moderate symptoms in non-hospitalized individuals with positive COVID-19 test results and who are at high risk for progression to severe disease, which includes hospitalization or death, or in short, those residents, clients that are in your facilities. The first line treatment of choice is Paxlovid, which is the novel antiviral agent, nirmatrelvir, that is co-administered with the antiviral ritonavir. And Paxlovid earned this first line distinction for several factors, but primarily it demonstrated an 88% relative risk reduction in the progression to severe disease, and that was pre-Omicron. I'm going to cover Paxlovid in more detail in the coming slides, but I do want to touch briefly on some of the other agents listed. So the second line agent is at the bottom there. That's Veklury. We probably all know it as remdesivir. That's how it was initially authorized. It demonstrated an 87% relative risk reduction, but there are some additional considerations for its use. And this is actually another agent that I'm going to touch on in a couple slides. So there's a red X on the slide. For whatever reason, they're still listing the monoclonal antibody, bebtelovimab. It's actually no longer authorized for use as of November 30th, and that's due to this, really what are the predominant circulating subvariants of Omicron, which are BQ.1 and BQ.1.1. And they are demonstrating resistance to this treatment option, so the FDA has pulled the EUA for this product. So as of today, there are no currently authorized monoclonal antibodies for the treatment of COVID-19. Now, the final agent you'll see listed there is under the oral antivirals. That's Lagevrio or molnupiravir, and this is listed as an alternative. So what they mean by alternative is that you should only use it when the other treatment options are not either available, feasible to use, or clinically appropriate. And this is probably likely due to its relative risk reduction of progression to severe disease being only at 37%. So it's not as strong of a relative risk reduction compared to the other two agents. The CDC just released a Health Alert Network update yesterday, and it confirms that Paxlovid, Veklury, and Lagevrio are still retaining activity against these currently circulating strains of Omicron. So next slide. So this is a little updated data in regards to some real-world evidence. So as I mentioned earlier, Paxlovid initially had demonstrated an 88% relative risk reduction prior to Omicron, which ultimately had led to its authorization. But what you see here on the slide is some additional real-world evidence post-Omicron of a study of about 200,000 individuals who received Paxlovid within 5 days of their positive diagnosis. It also looked at those individuals in terms of their vaccination status. So if they had at least 3 previous mRNA vaccines, hospitalization was 50% less likely across all age groups, and then in the greater than or equal to 65 population, 47%. And when they even backed that number of prior mRNA vaccines, so it could be obviously the monovalent and the bivalents, back down to 2 prior mRNA vaccines, that 50% reduction in hospitalizations continued to hold. And this data, as I mentioned, was recently published, and it was, I think, earlier this month in December in CDC MMWR, and you can see the link at the bottom of the slide. Now, Paxlovid it is readily available. Just know that there will be delivery delays in the next coming weeks with the holidays. And I know for some of your locations, I'm sure delivery delays are something you might deal with already. So there is a great tool that the U.S. government has put out. It's a COVID-19 therapeutics locator tool. So if you're able to put in, your location, it will tell you which, pharmacies and health systems around you have the product, because there is reporting that's required to maintain Paxlovid. We can move on to the next slide for some clinical pearls. So I really wanted to put information on this slide that kind of represents a lot of the questions I've received more recently about Paxlovid from our clients. Just know that unlike influenza prophylaxis and treatment, where you're starting within 48 hours with the COVID treatments, you actually have an extended period of time. So it should be initiated as soon as possible after a positive diagnosis of COVID-19 within 5 days of symptom onset. And it has to be prescribed individually, which has led to some issues with pre-positioning product, like in an emergency kit type of situation. It is a full 5-day treatment course. So like with any antibiotic or antiviral, we want to make sure that we're completing the entire treatment course just to prevent any potential resistance that could occur. And this is kind of has two presentations or two uses, two different dosing regimens. So both of them are 5-day treatment courses, but there is either 2 or 3 tablets that are given twice daily. And I'll touch on that here in a second. Something that we've been hearing a lot of questions about and some reports of is this being used as prophylaxis. So that is not a EUA indication, if you will. This is not to be used as prophylaxis. It's treatment only. In fact, Pfizer actually released a study earlier this year that showed, among individuals that had household contact of someone infected with COVID-19, they tried a 5-day and a 10-day treatment course to see if it would work as prophylaxis, and there was not a statistically significant difference in the rates of infection as compared to placebo. So for that reason, this is not to be used as prophylaxis because it does not show that it works for prophylaxis. So the reason that it could be 2 or 3 tablets twice a day for 5 days is because it is renally dose adjusted. So the images really on the left are the 2 different ways you might receive a renal dose adjusted Paxlovid. So the image on the bottom, when Paxlovid first became available, it was only available in one form, and the pharmacy would have to pop out 2 pills. And they would put a sticker over where those 2 pills were. So that's the bottom one. But then they came out with a renal dose, which is on the top there, where they don't even fill, those where the pills will go. That is not filled with a pill. And what I've included at the bottom, also important to know, that's not renally dose adjusted by a creatinine clearance, but it's an estimated glomerular filtration rate. And you can see the cutoffs there for the different doses. So if it's under 30 mLs a minute, Paxlovid is not indicated for use. And the one thing I didn't touch on are the plentiful interactions due to the ritonavir component. So next slide. So there are a lot of drug interactions with Paxlovid, and it's not the novel nirmatrelvir, it's the ritonavir component. That's been out for a while. It's often used to boost the availability, if you will, of another agent. Has been used in the past in HIV treatment regimens, and they're using it here to increase the availability of their nirmatrelvir. There are several tools at the bottom listed on the screen. I also recommend you work with your pharmacy or consultant pharmacist. Just know that because there is an interaction does not mean that an individual cannot receive the medication. Those tools listed below, the EUA fact sheet, they actually provide some guidance around mitigating those interactions. It's either usually by a temporary pause or a reduction in dose. And as you can see on the slide here, there's actually really very few interactions that would preclude its use in an individual. Something I failed to mention on the previous slide when we talked about even the renal rates is another thing I've been asked about is like, do you need a stat lab to understand what that individual's renal function is? And the short answer is no, not necessarily. There's actually a tool that the FDA has put out, if you haven't seen it, but it's called the Paxlovid Patient Eligibility Screening Checklist and Drug Interaction Tool. There was a link at the bottom of the slide on the previous slide. And it actually goes through kind of all the things that need to be considered for Paxlovid, and it really breaks it down and makes it easier to digest. But part of that, you may have seen this in the news, but state licensed pharmacists are able to prescribe Paxlovid for the treatment of COVID-19. And in their guidance, all they need is a lab that's within the past year. And then if there's no suspicion of a change in that individual's renal function, no suspicion of an acute kidney injury, anything like that, then you don't necessarily need to get new labs as long as you have labs within the past year. Next slide, please. Something else you might have heard about with Paxlovid is COVID-19 rebound. There's been some high-profile instances of this, including President Biden and Dr. Fauci. And put simply, it's a rebound of symptoms and/or a positive COVID test following treatment with Paxlovid. But what's important to know is we mainly have heard about it with Paxlovid, but it has occurred with molnupiravir as well. So it's not necessarily related to Paxlovid or molnupiravir, but it's probably part of the disease process or disease course in some individuals. If there is a rebound, an additional course of treatment is not recommended, nor is an extended duration of therapy. And individuals are recommended to follow the isolation procedures again. And something important to note is that the rebound is not associated with progression to severe disease. And all of this under consideration, Paxlovid is still recommended as first-line treatment. The next slide. Wanted to touch on Veklury. That is the second-line treatment and was initially authorized and approved only for hospitalized patients, but has since received approval for non-hospitalized patients, those that are at risk to progress to severe disease, have a positive test. And this particular one has some additional considerations for use as well, similar to Paxlovid. None of these agents are clean, so to speak. So this is an IV infusion, so you need to have IV access, given over at least 30 minutes on 3 separate days. This one you can initiate within 7 days of that positive COVID-19 diagnosis. And if you recall earlier, it demonstrated an 87% relative risk reduction in progression to severe disease. As you can see here, if an eGFR is less than 30, it's not recommended. And there are some additional warnings and precautions that have been shown with its use and observed. So from a cardiac standpoint, bradycardia, severe bradycardia, sometimes fatal, hypotension, reversible liver enzyme elevations, and infusion-related reactions, including anaphylaxis and angioedema, have been observed. This is also commercially available, so this is no longer a U.S. government purchase product, so there is a cost associated with it, so just be aware of that. However, there are CPT codes available for the reimbursement of this product as well. And that concludes my portion of the presentation.
Thank you, Stephen. If anyone has any questions, feel free to drop those in chat. And as we go through our open office hours, we can take a look at those. So thank you very much. So next up, we have treatments and wellness, what you need to know. I'd like to introduce Linda Allen. She's a registered dietitian, as well as a certified health coach. And the floor is yours, Linda. Thank you for being here.
Thank you. I appreciate Jesse inviting me to be here. And wellness is, in my opinion, looks different to each individual. Everybody's going to have their own idea of wellness. And if we could move on to that next slide, please. So You probably have heard this quote, and if you haven't, I think it's a great one. Making time for wellness. If you don't make time for your wellness, you will be forced to make time for your illness. And I'm guessing many of you have heard that. If you haven't, it's a good reminder. It's a good reminder for me. And so just think about what that means to you. What do you need to make time for in your own wellness? We are all busy. We take care of other people. That's what we do. We're caregivers. And so do you take care of yourself? So one thing to remember, and it's a basic exercise recommendation, is 150 minutes of moderate exercise per week minimum is what's recommended. And you can use the talk test to know if you need to step it up a notch when you're out for your walk, or if you're in Montana, you're probably not outside walking today. It's very cold, but let's say you're on the treadmill or you're doing something else that you love to do for exercise. If you feel like you could sing, and I'm sure you're not going to be singing in the gym on a treadmill next to other people, but if you think that you could, then raise your elevation or speed it up to a point where you don't think you could sing, but you could talk. That's how you judge moderate exercise. Not necessarily checking your heart rate, although that's another way. When we're done with this, Eric and Petey and Mutual Rescue Film is a wonderful YouTube video. I think it's about a 5-minute video. We don't have time to watch it today. It's a tearjerker for some, so keep some tissue handy, but it ends on a very happy note. It's a wonderful motivating film. I just love it, and I wish we could watch it today. Next slide, please. So do we ever think of sleep as part of wellness? Do you get enough? So think about that. Sleep should be part of wellness. We can be on the go, we can be exercising and eating right and doing everything top notch, but do you get enough sleep? It's a time for our body to heal and detox. So studies have shown that those who get 6 or fewer hours of sleep a night have higher levels of inflammatory proteins in the blood than those who get more. And another tidbit of information is those that regularly get over 9 hours of sleep per night, actually that might backfire and create another set of problems. So let's do the polling question. How much sleep do you get each night? Less than 6 hours per night? 7 or more hours per night? More than 9 hours per night? Okay, so it looks like most of us are getting good sleep. Some of you are burning the candle at both ends, it looks like. So anyway, let's go ahead and we'll finish up. And yeah, so anyway, if you're getting less than 6 hours of sleep, it might be time to just think about, how can you get better sleep? How can you get more sleep? Next slide, please. All right, I think most people think about, not most, but a lot of people think about weight loss. They think about that number on the scale. And I gotta minimize something here. I keep seeing that poll. How do I get rid of that? Okay, there we go. Okay. So consider when you are stepping on a scale, or maybe you're at the doctor's office and he's saying, okay, your body mass index is such and such. And some will actually compare it to what were you in high school. Is that realistic? Maybe, maybe not. So being healthy does not mean having a body mass index or a BMI less than 25. You can be healthy at any size, that in my opinion, and there are a lot of dietitians that would agree with that. If you are at a BMI greater than 25, based on the studies that led to the diabetes prevention program through the CDC, as little as 5 to 7%, ideally 7% weight loss, coupled with 150 minutes of moderate activity per week, could potentially prevent chronic disease such as type 2 diabetes or better manage chronic disease. So let's just say, for a nice even number, you weigh 200 pounds. If you wanted to lose 7%, it's 200 times 0.07, and that gives you the number of 14 pounds. So you could take your weight times 0.07 and come up with 7%. So that, along with the 150 minutes of exercise per week, can potentially lead to much better health. And one thing about the activity, having, let's say you do your 150 minutes over a weekend and then you are sedentary for the rest of the week. That's not what's recommended. It's recommended to spread that through the week and have it be in at least 10-minute pieces of exercise. At least 10 minutes is what's recommended for the moderate activity. Next slide, please. So when you're trying to make better food choices, because you can out eat your exercise. Let's say you are just exercising all the time. It's really easy to out eat it. And it's easy to make choices that aren't the most beneficial. But if you're really wanting some information on basic, good, healthy guidelines, the diet that is used for or recommended for diabetes in general is a good diet for most of us to follow. And so if you look at the plate shape, and this would be a 10-inch plate, if half of your plate is non-starchy veggies, and only a fourth of your plate is protein, and that would be equivalent to about the size of a deck of cards or the palm of your hand. And then complex carbs would be the other fourth of the plate. So that could be, like it shows, a yam, it could be some rice or pasta, quinoa, corn. And by the way, popcorn is a whole grain, and it's recommended by the American Heart Association that at least half of our grains are whole grains. And what you don't see on that slide is a picture of a dairy and a fruit. So a lot of people don't drink dairy, but a good equivalent option would be soy milk, or if you choose maybe almond milk, you could get your calcium that way if it's fortified. Just know that some of those milk alternatives have very little protein, such as almond milk, or you could maybe replace it with yogurt and then a fruit. So maybe you don't want to have all these things at one meal. Maybe you spread them out and have some of them as snacks. And down at the very bottom, it gives you some good ideas on how to judge what a teaspoon is. It's actually from the knuckle of your thumb up to the tip of your thumb is equal to a teaspoon. A tablespoon is equivalent to about your whole thumb. So let's say you have a tablespoon of peanut butter. You can judge it by looking at it. So anyway, there's some tips like that. Next slide, please. So when you're trying to figure out food stuff, if you do nothing else, just incorporating more foods that grow from the ground up, that are not processed, that are in their whole food form, if you could just do that more often than you're doing now, if you don't already do it, that's one place to start. Foods that grow from the ground up, they can actually help improve the gut microbiome, those good gut bacteria that need to be in our guts. By the way, lack of sleep can reduce the gut, or negatively affect the gut microbiome and increase appetite, because gut microbiome is related to our appetite sometimes. It can also be related to glucose sensitivity. So foods that grow from the ground up could potentially reduce inflammation. They're full of antioxidants. They contain vitamins, minerals, and fiber and water. So that helps you stay full, to get full and stay full longer if you have more fiber and water. And in my opinion, you cannot package all that's in whole food that grows from the ground up in a supplement. You just can't do it. They don't know why, they still can't package it. There's a lot to whole foods that I think we'll forever be learning. Next slide, please. All right, let's backtrack. So all those things, I think we all kind of know what to do. And sometimes it can be very daunting. And maybe you're already doing it. Maybe you're doing all those things and you feel like you're trapped in a box of rules and regulations. Or maybe you've tried all sorts of things and you just can't seem to stick with it. So here's some common things that I hear, and you probably heard from people when they try to make changes, or they try to lose weight, or they try to make wellness changes. I feel defeated. I'm so sick of starting all over again. The only thing that works for me is extreme measures. And you've probably known people that do take extreme measures to maybe lose weight or to get healthier. I'm thinking about food all day long. I just don't know how to eat anymore. Or I just don't have the motivation to start another food plan or lifestyle change. You know, they're burnt out, they've done it all. Or I'm so motivated during the day and have zero willpower at night. Here's another one. I can't keep any candy or other favorite food in the house. I have no willpower. Or I'm eating nonstop while watching TV at night. So if you're in one of these categories, and I'm guessing somebody here today is, and you're just feeling like I can't keep doing this, it's not working, then consider a different approach, and it's called intuitive eating. Next slide. So intuitive eating basically is a way to relearn and help improve our relationship with food and take the power away from food that we've given it. You know, when we're born and we're young children, we knew when we were full, we knew when we wanted to eat. You can imagine a baby, they turn their head and they don't want anymore. You can't force feed them. And the adults in our lives, and I'm sure I did it to my kids, we encourage them to eat when they didn't want to eat anymore. So we train our young to eat when they're not hungry, or maybe eat when they're not happy, eat for any other reason. So basically, intuitive eating is ditching diet rules and making peace with food in your body. And it's based on a book that's, I think I might have it listed in the resources, and it's intuitive eating. And maybe this is the wellness piece you need. Maybe you need to step back and just relax, because sometimes those diet changes backfire. And actually, every time you lose weight, you're losing some muscle mass. So then when you do regain that weight, you're not regaining muscle mass, you're regaining fat mass. So then it's a cycle. Then your metabolism slows, yada, yada, yada. Next slide, please. All right, so I've given you a whole menu of things to think about for wellness. Again, I do believe that whatever you need to work on or feel like you need to work on, and maybe it's nothing, maybe you've got all your ducks in a row and things are going good, but I could imagine most of us can improve on something. So think about this. Think about those different things that are ideas. That's all I'm just providing ideas, but also think about how much time are you sitting in front of a screen. I'm guessing that most of us are sitting in front of a screen right now. I am. We work a lot of times in front of a screen, unless you're on a standing desk or a walking, maybe you've got a walking desk where you have a treadmill underneath, but most of us are sitting. So besides that, and maybe watching TV at night and so forth and so on, there's a there's a YouTube video that's another one that I think is top notch. I could not say everything that this will tell you in 4 hours because he condenses wonderful information into about 9 minutes. Highly recommend it. And in here, he says the average adult in the United States spends about 5 hours per day sitting while watching television or other screens. So be thinking about that. How long do you sit? He ends up saying basically, well, it's called 23.5 hours. So I'll let you figure that out or watch it for the end. And he does quote, "Walking is a man's best medicine," by Hippocrates. So if you're not out there moving and exercising in some way, maybe walking is where you start. Next slide, please. And maybe everything is overwhelming and, you really just don't know where to start, even if kind of like, okay, I really want to work on this. I highly recommend this book, Atomic Habits by James Clear. It was recommended to me by another dietitian and I bought it. And every time I read any part of it, I continue to have aha moments. And I noticed that on Amazon, the hardback is only $0.01 right now. It's a good price. And it could apply to sleep, your food choices, exercise. It can, if you want to use his principles for finances, that's another thing. Or maybe you have a closet you need to clean out and it's too overwhelming to even think about. Even his principles can help you with those types of things. But I think it's a great book to change and work on the habits that are involved in wellness and, eating and exercise in particular. And I believe this takes us to the end. So is there another slide that's just the resources? So that is it. And I don't know if we have any time for questions, but that's it. And thank you again so much for inviting me.
Thank you, Linda. And I did put the resource links in the chat box for those of you that want to snag them. And then, of course, we record our sessions and we will send out the any questions and the recording and the slide deck next week. Any questions for Linda or Stephen while we have them on the line? I will say that Stephen just shared those CPD codes he was mentioning regarding remdesivir to help with cost, and I will send that out on the listserv. Well, thank you both to our guest speakers. Thank you to the audience. Everyone, have a wonderful holiday. We will see you after the new year. And stay well, stay warm wherever you are, and happy holidays. Take care.